Welcome to the AMR Clinical Education video series. Today we'll be discussing we have 4 protocols we will be reviewing today. Termination of resuscitation, pediatric airway management, pain control, specifically the ketamine dosing, and finally, respiratory distress protocol. Beginning with the termination of resuscitation protocol, we have revised the protocol to utilize a checklist. Dr. Duncan and I have reviewed protocols from across the local region as well as the nation and looked at best practices to develop this protocol. We've decided to utilize a checklist-based protocol based on the findings of these best practices. Paramedics can now utilize the checklist and terminate resuscitation efforts without having to contact medical control. This gives paramedics the ability to exercise their judgment within their scope of practice, provided all the components of the checklist are met. The important thing to stress is that if there is any doubt, or if not all the criteria are met on the checklist, medical control should still be contacted. The intent of this protocol is to be another resource, but it must be utilized and completely filled out. The checklist will be a required component of the documentation, and it needs to be attached as a trailing document to the EPCR. Here's a look at the protocol. The indications of cardiac arrest patient with 30 minutes minimum of appropriate therapy. Studies and experience show that we are generally getting ROSC between the 20 and 30-minute mark. We want to make sure that we're giving these patients a fighting chance. Some contraindications to utilizing the checklist include those situations where an extended resuscitation effort would be indicated, such as hypothermia, drug overdoses, and carbon monoxide poisoning. Any patient that has a return to spontaneous circulation or signs of life would not be a candidate for inclusion to use the checklist. Finally, if the patient's family desires transport, or if the scene becomes unsafe or is in a public location, the paramedic should use their clinical judgment if a field termination is appropriate. The protocol is fairly simple. Follow the appropriate cardiac arrest protocol. It is important to stress that end-tidal CO2 must be monitored on all cardiac arrests. The end-tidal CO2 needs to be documented. If it is less than 10 millimeters of mercury, after the cessation of compressions, the provider can use the checklist to terminate the resuscitation effort. If all the other criteria are met, then the paramedic can terminate without calling medical control. If there are extenuating circumstances or the criteria on the form are not completely met, then the paramedic should consult medical control. According to this protocol, the time on the terminal rhythm strip generated by the monitor is the official time of the termination of death, or termination of resuscitation. And so that is the time that should be put in the documentation and relayed to dispatch. Dispatch should be notified so they can also notify the appropriate law enforcement agency. In the event of a PEA code, standard practice is to confirm that the patient is pulseless by feeling for pulses, auscultating for heart tones, and assessing the end-tidal CO2. If the end-tidal CO2 is greater than 10 millimeters of mercury, then transport should be considered and medical control should be consulted. Finally, quality documentation is key. The EPCR should include all the cardiac arrest fields and the treatments provided in the treatment section. These fields are important as we do report the data to a national registry to track our local survival rates, but we use the data to improve resuscitation. The narrative should be complete and paint a picture of the scene, as there will be multiple people reviewing the report that will need to know what the situation surrounding the death were. Please also remember to transmit your monitor data to code staff so we can review the call and perform process improvement. Let's look at the termination of resuscitation checklist. We need to ensure that high-quality chest compressions have been performed, that we have an advanced airway placed, and that the placement of that advanced airway has been confirmed. We need to ensure that we're monitoring end-tidal CO2, and that at the termination of resuscitation, that the end-tidal is less than 10 millimeters of mercury. We need to ensure that vascular access has been obtained, and that the appropriate protocol has been followed per ACLS. We need to document the protocol that we're following and ensure that we have provided more than 30 minutes of ACLS resuscitation efforts. We need to verify that there has not been any sustained ROSC at any point during the resuscitation. If we have received any ROSC, we need to consider transport. If the patient is presenting in a persistent VFib or a VTAC, then we should transport them, as the underlying cause to the cardiac arrest may be treatable. We want to verify that there are no signs of life. The GCS should be documented of 3. If the patient is presenting in asystole or anagonal rhythm, then that's definitely an indication for termination. We want to make sure that we identify and treat all the reversible causes, ensuring that we've gone through the H's and T's to cover all of our bases. Finally, all the providers need to agree on the termination. This is a team effort, and every team member should be involved in the decision. This section also gives us a stipulation for pediatric termination. Providers should discuss the resuscitation effort and the decision to terminate with the parent or guardian and provide enough information that they can make an informed decision regarding the termination. If the parent or guardian is in agreement with the termination, then it is acceptable to terminate resuscitation. Remember, if any of these criteria are not met, medical control contact must still be made. Pediatric airway management. The pediatric intubation has been removed from this protocol. Dr. Duncan has had multiple discussions with other local medical directors who reviewed multiple studies, as well as the recommendations from the AHA and ILCOR. These studies have shown that pediatric patients that are intubated in the pre-hospital settings have worse outcomes than those who are not intubated. This means that the patients that we intubate, as opposed to just using basic airway management, have a significantly worse outcome. They're not surviving. And so, to bring our protocols in line with the current recommendations, that's why we've removed pediatric intubation. So the emphasis is now going to be on quality BLS airway management. Sticking to the basics, positioning the airway, using simple airway adjuncts, and positive pressure BVM ventilations. And this brings our protocol consistent with the recommendations of the AHA as well as ILCOR. Now we realize there still may be a need for advanced airway management. So the approved airway will be a supraglottic airway. Here at AMR and Independence, we're carrying the King tube. We now have a size 2 and a 2.5 for the pediatric populations. It's still permissible to intubate a newborn solely for the removal of meconium pursuant to current PALS protocol. So here's a look at the revised protocol. The only change really is the removal of the ET tubes and the addition of the supraglottic airway as the primary ALS airway. Remember, end-tidal CO2 is the gold standard to confirm placement and must be monitored anytime an airway is placed. Ketamine dosing. We've had ketamine for about a year now, and we've had our share of issues, but we've also seen the benefits. So one of the issues that we have had is mostly related to dosing. we see either an over or an underdosing of our patients. So to combat this issue, Dr. Duncan is changing the dosing for pain control, reducing the dose and simplifying the math. This change also puts our protocol in line with the physician's protocol at Centerpoint. If your patient is 70 kilograms or less, the new dose will be 10 milligrams of ketamine mixed in a 50 milliliter normal saline IV bag, administered as a slow drip over 10 minutes. If the patient is heavier than 70 kilograms, the new dose will be 20 milligrams of ketamine mixed in a 50 milliliter normal saline bag, administered as a slow drip over 10 minutes. The benefit to administering ketamine as a secondary pain control as well as a drip is now we can titrate it to pain relief. So if your patient, you start the ketamine on your patient and their pain goes away pretty quickly, we can stop or slow that drip. And if their pain comes back, you just turn the drip back on and we can effectively control their pain by titrating to their pain relief. So currently we carry ketamine in a concentration of 100 milligrams in 1 milliliter. So to get the 10 milligrams of ketamine, you should be pulling up 0.10 milliliters of ketamine to mix in your 50 milliliter bag of normal saline. For the 20 milligrams of ketamine, you should drop 0.20 milliliters of ketamine to mix in the 50 milliliter bags of normal saline. We are looking at ordering different concentrations to make this process a little bit easier. Now remember, ketamine is a secondary pain control medication. Providers still should be administering morphine or fentanyl as your primary analgesic. If you reach the max dose of the primary analgesic and the patient's still in severe pain, now we can add ketamine to the pain control treatment. In the event that the patient has a true allergy or an absolute contraindication to the morphine or fentanyl, or there are other extenuating circumstances, paramedics should consult online medical control prior to administering ketamine as a primary analgesic. The behavioral dose of ketamine has not changed and will remain 1 milligram per kilogram intravenous or 2 milligrams per kilogram intramuscular. Here's a look at our pain control protocol. Morphine and fentanyl are still our primary analgesic. The patient is still experiencing severe pain. After receiving morphine or fentanyl, we can add ketamine. So let's review the dosing. Again, if the patient is 70 kilograms or less, mix 10 milligrams of ketamine in 50 milliliters of normal saline and administer it over 10 minutes minimum as a slow drip. If they're over 70 kilograms, we're going to mix 20 milligrams of ketamine in 50 milliliters of normal saline, administer it over 10 minutes as a slow drip. The nice thing about this method is if you get half the drip in and their pain is gone, you can stop the drip. And if the pain returns, you just start it again. So we can titrate the ketamine to their pain. Finally, we're looking at the respiratory distress protocol. There's really been no significant changes to this protocol. However, Dr. Duncan would like to place an emphasis on getting intramuscular epinephrine on board early in younger patients less than 40 that are starting to shut down after other treatments. The change to this protocol is the addition of magnesium sulfate to the protocol. And this is going to be for reactive airway disease with wheezing refractory to albuterol treatments. So if we have an asthma or a COPD patient that is still getting worse after receiving albuterol, Atrovent, Epi if they're less than 40, and CPAP, we can now add magnesium sulfate to our treatment. The dose will be 2 grams slow IV drip over 10 minutes. We do not want to push this very rapidly. So to simplify this process, we now actually carry a pre-mixed 2-gram bag of magnesium sulfate. And so all you got to do is hook up your IV tubing and hang it. So here's a look at the protocol. The significant change again is the addition of magnesium sulfate. This is to be considered after we have progressed through the treatment algorithm. Following the flow, we need to be considering CPAP early, nebulizing the bronchodilators through the CPAP, and considering epinephrine early in patients younger than 40 years. If they're over 40 years old, we need to be consulting medical control prior to administering epi. If we're getting to the end of those treatments, we still have minimal improvement and we're still seeing a worsening patient, we can now add magnesium sulfate. Remember, the dose is 2 grams, slow IV drip over 10 minutes. Thank you for your time today. If you have questions, feel free to reach out to me. Pete Whiting, I'm the Clinical Education Specialist for AMR here in Independence. My contact information can be reached at my office, 816-836-1594. My extension is 21908. Or if you follow the prompts, extension number 3. I can also be reached by email at donald.whiting@amr.net. Again, thank you for your time and your commitment to clinical excellence.